Thanks for sticking around for this last session.
Oh, thanks.
Yeah. So Maria and I are going to tag team this.
Yeah.
I'm Hemal Kanzaria. I'm an emergency physician at UCSF and ZSFGH, and then have a dual appointment with our Department of Public Health in San Francisco County, where I work on issues around care coordination and social determinants of health.
Hey, and I'm Maria Raven. I work with Hemel, also at UCSF. I'm on our research faculty, Health Services Researcher and Program Evaluator. We work a lot together, and I have an appointment at the Institute for Health Policy Studies at UCSF also. So the first question that we have for you, we want to make this a little bit interactive, is have you all had any advocacy-related interaction with like a government official or a public health official? And if so, what about that went well and what didn't go well? Anyone? Yeah. Here.
So I've had a lot of them. I used to testify at FDA hearings, but in my state, we have a lot of people who the same bills come up every year, and you know ahead of time whether or not the person has voted for your bill positively or negatively before, because you're pushing a bill that has come through session 3 or 4 times in a row. So I think what goes well is knowing what someone thinks ahead of time is super helpful to your experience. And obviously the alternative is also true. If you know someone is decidedly against you, you still have to make an effort, but it is very frustrating when you show up and they're like, well, I've already made up my mind. I'm not open to any thought. But just kind of tagging on to what they were just talking about, I would just say that I'm obviously, I'm a med student, so I don't have as much experience as a lot of people in the room, but I'm a big joiner, so I join everything. And I think having as many people in your corner as possible is so helpful, and saying like you disagree with people that you've never met is kind of ridiculous. So I think what can always go better is like lining up as many people on your team as possible before you get there.
Other thoughts on that or any other experiences? The way we're going to do this session is we're going to sort of highlight how we have worked with local government in San Francisco, but basically pose sort of 7 to 8 questions to you all. So we put out these pads of paper and pens, and there's just going to be a couple sort of simple writing exercises to think about how you would actually go about advocating in a local government setting. And we encourage just interaction as to the extent that you all want to. So the first question really is to identify your passion or your topic of interest, and figure out what your stance is on that, and then why that's important now, and why are you advocating for that right now. So if you could take just a minute or 2 and just jot down 1 or 2 sentences about sort of whatever you feel passionate about and sort of why it's important at this moment. And we'll go through sort of our responses to that as well. And then just look up when you're done, so we keep going. All right, I see a couple heads nodding up. Would anyone be willing to share their topic of interest and their response to these questions?
I saw a lot of people writing. A lot. Someone.
Yeah.
Harrison. And then.
Excellent.
Emergency departments can help solve some thorny social problems because people with social needs congregate there. My stance is that we need to be supported to integrate with other actors. Why is it timely now? Because social inequity is reaching a crisis point.
Great.
Great.
I think I saw, did you reach? Yeah. Sure. Here.
So on MAT prescribing in the ED, I would say that my stance is that it's important that we reduce barriers to emergency physician prescribing of buprenorphine, including things like requiring the X waiver, and you look at ways to maybe eliminate things like that. And why it's relevant now is obviously we're still in the midst of an opioid crisis, and also we now have evidence that when we start this in the ED, patients continue with it.
Great.
Great. Maria, what do you think? Like, what would your response to these questions be?
So I'm very interested in just the idea of the kind of quote-unquote frequent flyer, which is a pejorative term that's just up there because that's what people say, and unnecessary, again, quote-unquote emergency department visits. So my stance is that there isn't really any such thing as an unnecessary emergency department visit. By the time someone's there, the visit was obviously necessary, whether or not you can understand the reasons why that might be. And the reason that we have a lot of those visits is because emergency departments aren't set up to be able to deal with a lot of the social needs that people have. And the reason that's important now kind of gets to what Harrison and some of you all were talking about, is that this is a time of sort of unprecedented inequality and a lot of social need.
So I think some of the key points in hearing Maria talk about sort of her experience. One is that this is a commonly cited topic in the lay press, commonly highlighted the term unnecessary ED visits and the frequent flyer. She's using these terms right now as a way to meet people. If reporters are calling her, they're using those terms. If the lay press is talking about it, they're using some of these terms. But she also has a somewhat unique perspective on this, and it's one of those moments where you can help someone else have an aha moment. And she's written extensively about this topic and spoken publicly on this topic at national conferences. So it's really an opportunity to sort of reframe the sort of message around it. But good. So basically, you got to pick your topic that you're going to move forward with, and sort of know why you're going there.
Yep.
All right.
All right. So this next thing is a little bit about who you are. And what we want to talk about here is how you might, there have been a couple questions that have come up throughout, kind of like how do you get into an organization? How do you relate to media? So we want to talk a little bit about how one might introduce themselves. And so we want to, again, in an exercise, how would you introduce yourself, where you live or work, and why you might be uniquely qualified to comment on perhaps the issue that you wrote about. So we're going to ask you again, 2 or 3 sentences, kind of come up with the statement of who you are and why you're qualified.
So the issue that I chose was the interactions of ICE and immigration policy with our healthcare services. And I think I'm qualified as a emergency medicine physician at Boston Medical Center, which primarily serves the Haitian and Latino populations in Boston and is also the medical control for Boston EMS, where we see a lot of these interactions.
So you've seen a lot of this firsthand.
The issue I address is the medical care of undocumented immigrants, which is very similar. And I've trained medically and done residency in New York City, work in a hospital, frequented almost exclusively by immigrants. I've also worked extensively in areas where many of these people are coming from and understand both sort of the push and pull of immigration and the unique aspects of caring for undocumented patients.
Great. Okay. So Hemel is going to tell us who he is. So Hemel, tell us a little bit about yourself and why you're qualified to speak on a specific topic.
Hi there, everyone. I'm Dr. Hemal Kanzaria. I am on faculty at UCSF, and I work clinically in the ZSFG Emergency Department, which is the safety net facility in San Francisco County that serves over 1 in 6 San Francisco residents. I also am a health service researcher and have published and spoken on the topics of homelessness and frequent ED use. And then finally, I live with my family, including my 2 daughters in San Francisco, who both go to school in San Francisco, and I'm acutely aware of how the housing crisis and income inequity really has translated into the medical delivery system and where some of the challenges are that we face right now.
Okay, so notice a couple things there. First of all, pretend he's wearing his white coat, which you should do if you're in a situation like this, or scrubs. So you kind of want to look like a doctor, right? And then he started off saying he's a medical professional, and I think the cool thing about what Hemel just did is he not only gave his, talked about his kind of vast experience in kind of the research world and clinical care world, but he also said, look, I'm a resident of San Francisco, and if you're talking to like a legislator or someone else, they're going to care about that because you're their constituent. So it's sort of 2 things. And then we also just want to highlight that this is not a time to be modest or shy. Like you're an emergency physician. You're on the front lines. You're seeing this. You should talk about your experience. And also, if you do have papers that you've written or an op-ed or other pieces, maybe you've done expert testimony, bring this and show it to the person to kind of demonstrate your expertise.
I think we put some tips that you can use, like specific words that physicians can use when they're doing any sort of legislative advocacy or administrative advocacy. And so sometimes, we'll pull in, like, in my experience as a physician, I do care for patients who come in with heart attacks, but honestly, even more commonly, I take care of patients who are experiencing homelessness and substance use and mental illness and firearm violence, and sort of really hit home that, like, this the full spectrum of my role as a clinician. So really bring, like, the value that you add is one of the many values is that you're a clinician and you take care of patients and you really know the issues in a really real way that sometimes legislators or decision makers don't have that insight. So really bring that insight to them.
Perfect. And also, of course, tell stories about your patients because people love that. And we'll talk about that a little bit more. But data is great, but also, as I think someone said earlier, anecdotes are also really helpful for people.
Yeah. All right. So next exercise is really identifying who your audience is. You may have multiple different audiences. Jay talked about working with the ASAP board of directors. In our work, we're dealing at the city level, but I want to, for this couple minutes, if you can think about, again, with your topic of interest, identify who is your audience. Is it the general public? Is it your city council? Is it, ASAP? Is it Department of Public Health leadership? And then what do they need to know specifically? And I encourage you to be sort of specific and focused. And why should they care about it at this time?
Okay. Anyone? Someone who hasn't spoken yet?
So some of the work that I've been able to do so far as a medical student is requesting and helping coordinate some curricular change for the students in classes below me, centering around transgender health. So a lot of my target audience in the past has been medical school administrators and professors who help facilitate that learning. I think what they should know is that transgender health is a longstanding and rapidly growing health need in Middle Tennessee, and that medical students both at Vanderbilt University and across the nation should know very key things about taking care of a transgender individual and what they need, and being able to be culturally competent with them to make them feel comfortable in a healthcare setting.
That's great and very, very, very important, and I think coming much more into people's kind of knowledge, and I think it probably is really important for you as a student to educate people that are more senior to you that may not be as well versed. So that's really great. Anybody else? Okay. So for Hemel and I, we do some work in San Francisco County with a program called Whole Person Care, which is a big, like many millions of dollars Medicaid initiative to improve care for homeless individuals in San Francisco who are frequent users of the acute health care services. And they have these whole person care programs in many California counties. But for us, our target audience, so we're sort of like the UCSF researchers that were brought in to be the evaluators of the program, but we're also helping a little bit with implementation. And our target audience is the mayor's office and the county board of supervisors. And it's really important to know who is on your board of supervisors and kind of know a little bit about their background. So if you're going to go talk to them, kind of as you were saying, you kind of know what they might be, how they're oriented. And then the Department of Public Health and Supportive Housing, we work with them all the time, and we really have to get kind of to know the players in those two organizations and how any political things about how they might interact with one another or might be competing for resources. So what we feel like they need to know is that many frequent emergency department users have very legitimate medical complaints and also very complex social needs, as we talked about before, but the emergency department isn't set up to address these needs. A lot of people think emergency department visits are quite costly, but actually the ED visits in and of themselves are not a major contributor to healthcare costs. But we do make 50% of the decisions to admit to the hospital, at least in the emergency department. So if you want us to do a good job and do right by patients, you need to give us enough resources to be able to do that and potentially prevent high costs by being able to avoid admission by treating some of these other social needs. And then finally, a lot of outpatient providers actually refer patients in. So some of the issue with frequent emergency department use is actually contributed by outpatient providers referring their patients in. And why should they care? Well, because we know from our research that frequent emergency department use actually predicts mortality. So these people are very sick. And then we're going to show you some data that we have from some of the work we've done. So, oh, did this not come out?
That's okay.
Okay. Well, so we probably know most of this well enough, but so 130 was the median number of. So this is the top 100 users of acute health and social services in San Francisco. So we looked at their data administratively, and then we did in-depth chart reviews. So on average of the top 100 users of these services in San Francisco, they had a mean number of ED visits that was 130 per year. Okay, so this is really eye-catching to policymakers because they may not realize how often this is like every third day, more than every third day, these people that are costing them a lot of money are coming into our emergency departments. We found out that I think only 17% of them were connected to a case manager, an intensive case manager. What? 17 of 100? And we also found that almost all of the top 100 were homeless or had a 99, had a history of homelessness or were currently homeless. So unfortunately, this did not all come through, but I will mention one other thing. 16 of the top 100 met criteria for a brand new bill that just passed in San Francisco called Senate Bill 1045, which says that if you've had 8 or more 5150s in a year, you are eligible for conservatorship. And that comes up for a couple of reasons we'll talk about later.
Involuntary psychiatric holds.
Yeah.
Sorry, I know the language is slightly different.
Yeah.
One other point before we move on is just in terms of knowing, so Board of Supervisors is also a San Francisco County thing. In other places, it's your city council members. And so really understanding who they are, signing up to get on their email listserv, so you get a sense of like what is on their agenda on their monthly meetings. And then when there is a health topic that comes up on the agenda, going to their meetings, having them get to know you and be like when they're looking for someone with health experience, having a person who they've built trust and relationship with over time can help you be in the right place at the right time, and is very effective at sort of a local government level.
Yeah, and I would say that I think both of us, we got the job to be the evaluators because we've worked with the people in the Department of Public Health and kind of gained their trust over a number of years. And that's why they were comfortable kind of giving us, as the academic physicians, a lot of data that we needed to do this. Okay. Okay, so the next thing is just to tell a brief story that supports your position. And so you want to make it true, and then you just want to change the details so you can obviously protect the PHI. So we want to just, again, do a brief, and it can be an anecdote about a patient you saw or an experience you had that would support the position that you're advocating for. We are running a little short on time, and we want to be respectful of everyone's time and get you out of here at 5. So does anybody that has not talked yet want to tell a story? Okay. Anybody?
I'll share mine to get us going on. So I help run a social medicine program at the institution I work at, and we're commonly meeting with, sort of legislators, and so this is a story that I've shared with them. So in February of last year, our team helped take care of Jane, who at the time was an 89-year-old female, unrepresented in this country, originally from Australia, but was here without any sort of friends or family. When we met her, Jane was living on the BART line. So the BART is our public transportation system in the Bay Area, and she would basically take the BART back and forth between San Francisco and Oakland all day long, and at night she would get off where the BART stopped, and she would basically sleep somewhere on the street unsheltered. During the daytime, she would take the BART back and forth, and unfortunately she suffered incontinence, and so was frequently in soiled clothes, causing bystanders who were trying to advocate for her to call the BART police. The BART police would come and pick her up essentially every day, every other day, and she basically bring her to a local emergency department. She had over 160 emergency department visits in the year prior to our team seeing and taking care of Jane. And one of those times she ended up in our emergency department, and the frontline ED team called this social medicine team, and we came and we sat with Jane. We tried to understand what were her priorities in that moment. So she said that she was hungry. She hadn't had a meal reliably in a while. She said that her bottom hurt. She had been sitting in soiled clothes for a long time, and so she had developed sacral ulcers. And she said that she was concerned that people were going to steal her belongings. She had all of her life's belongings in sort of frayed and tattered bags attached to her wheelchair. So we sat with her, and we provided her a meal. We reassured her that no one was going to take her belongings. We actually provided new bags for her to upkeep her belongings. And over time, over a couple hours, we started to develop some trust with her. She had lived on the streets for over 15 years, and so she was a little bit skeptical, but we introduced the idea of moving indoors that day from the ED. My team partners with a community agency that is skilled in transitional housing, and we called one of their case managers, Patricia, who came over and sat with Jane, and the two of them bonded over their love of clothing. Turns out Jane had been a stylist in a previous life in Los Angeles. And so basically with little more incentive than a couple, like a black skirt and a black jacket, we were able to incentivize Jane to move indoors to a psychiatric respite facility that night. From that point, and that was in February 2018, we've worked with Jane to get her an ID, to get her enrolled in entitlements, to have her eat food and keep nourished, and her sacral and bathe. So her sacral wounds have now healed. And in November of last year, we were able to help her get into permanent supportive housing. And she is part of a community for the first time in decades. And she's only had 4 ED visits since that time for UTIs.
Okay, so that's pretty amazing. Like, that's a pretty striking story, right? So that's the kind of story, and I mean, Hemel has pitched this to get money for his social medicine team. And he's gotten the money because this is what they do, and it's amazing. So you just have to really kind of dig in there. And they might do some other things that are not quite as amazing as this, but you should choose the thing that's like the most amazing example. They do a lot of amazing stuff.
And then, so we tie this with the next slide. So Jane is one of 2,300 patients like her that we have cared for since January of last year. Depending on who you're talking to, we present data that is related to their interests. So for our hospital exec team, we present data on readmissions averted or admissions averted and highlight some very basic numbers. And the point here is not the data. It's to say you don't always need an RCT. You can present simple run sheets for something like this. And depending who you're presenting to, you shift the data. So to my ED executive team, I talk about ED revisit rates. To the hospital execs, I talk about readmissions.
Yeah, and this might not get, right, like this might not be a trial that's published in a journal, but it doesn't really matter because you just want to show data that matters to who you're presenting it to so that you can continue to do the right thing and fund a program like this, right?
And then lastly, next slide, there are a couple of different ways of tying stories and data together. This is a very busy slide, but it's a way to integrate a story about John on the top left, who is a frequent ED user, who is homeless, who's using substances, and actually follow him across San Francisco County. And so the different bars underneath that mountain-looking thing are, each time he touches a different agency in San Francisco. So you have John who goes to the emergency department, and then he gets sent to a shelter that night, so he's touching both sort of our hospital system, our shelter health system. The paramedics brought him in, so he's touching EMS. He gets referred to Medicaid enrollment, so he touches the Human Services Agency. And this is called a journey map. It's a tool that people use in design thinking. And for us, what we've done with this is it's allowed us to bring multiple stakeholders from across San Francisco County together in one room to actually create this map together of patients like John. And then on the bottom are that similar statistics that Maria showed when she was talking about data. So it's a nice thing to pass around and to blow up and to have people get their fingerprints on and really get to understand the issue from multiple perspectives. Okay, so now this gets the ending part of our talk, but you have to be clear about what your ask is. So we wanted to, I think we're going to skip the writing for time purposes, but I want you to think about what do you want your audience to do with the information you're advocating for? What is the one thing that you want your audience to take away or to do after your conversation?
And you have
Sure. Can we make it so that first-year medical students at Vanderbilt University have at least 4 hours of required learning on transgender health?
Okay, great. So what I loved about that was that it's specific. There's a timeline associated with it, so there's some accountability associated with it. It's sort of, if you've heard of a SMART goal, he had a lot of components of a SMART goal, which we'll go through, and that was perfect.
And it's also actionable. Like, it sounds realistic, right, if you're the person that you're presenting to. So this is the stuff we were doing with whole person care, and based on the journey map and all the data we did on the top 100, we came up with a bunch of recommendations through big stakeholder meetings, and so we ended up coming up with 33 recommendations for the city and the mayor. And this is just to show you, you can't give anyone 33 recommendations. They'll just glaze over and they won't look at any of them. So what we did is we said, what are the top 5 things? It was difficult, but of these 33, we asked all the stakeholders, what are the most important ones? And the way that we did this was through some illustration, because you're an emergency physician, so a lot of this stuff is really you just know it so well that it's difficult for you to understand that other people may have no point of reference or no idea what you're talking about. They may have no idea that people are coming in psychotic using meth ending up on 5150s, or that like many patients you see every day in the ED are homeless. All these things. So you have to kind of lay it out for them. But this allowed us to kind of say, okay, here are our top 5 goals. So we did a story of Richard, a long-term resident of the streets in the Tenderloin, a substance user. So our first thing was we want people to be flagged and prioritized for services using kind of an electronic shared data system. So that was number 1. So here's a case manager reviewing the records using that system. We wanted a mobile community-based team, almost like an ACT team, an assertive community treatment team that could go around and care for these patients and provide services for them, potentially while they're waiting to get housing on the streets. And we wanted the team to be able to document all of this in that same medical into that same data system. All right. Then one of our other, so the third one was we really wanted in-reach into emergency departments. So I don't know if you're familiar with this world where you work, but in San Francisco, there are a lot of case management programs. There's an EMS 6, which is like a paramedicine team, and all these different, we have housing placement coordinators, all this stuff, but they're not coming to the emergency department, which is exactly where they should be coming, because that's where all of these patients are coming, right? And so this was, we wanted people to know how important it would be to mandate in reach of all of these teams into the emergency department. And then here we talked about, is this the cognitive? Yes. So this is, our other thing was we found a lot of in our chart reviews that patients had cognitive deficits that were not well documented. And so we thought actually some people would qualify potentially for conservatorship or were actually gravely disabled, but it just, nothing was being done. So they just keep showing up in the ED again and again. And so one of the other, our fourth recommendation was we think we need to have better access to like in-depth cognitive testing. And the last one was developing interagency measures for adults that are experiencing homelessness so that when we implement these things, we can see as sort of a community how we're doing, and we can develop these shared metrics across the system.
All right, so this is the final couple points, basically, that as an individual physician, you're rarely going to move the needle yourself on a large topic. So you have to identify partners. We talked about a couple experiences today, again, about partnering with within your professional society, but there's so many other opportunities that actually, as a physician, you'd be in a really unique place to partner with them. So these are some of the organizations that we have partnered with in our work. Tipping Point is a grant-making organization in San Francisco that has dedicated $100 million to homelessness, and so we've worked with them about how to direct those funds. Collective Medical is the vendor associated with the ED Information Exchange, and we've worked with their company to sort of integrate partnerships across California to better integrate data on frequent users. The Coalition for Homelessness is an advocacy organization that partnered with many physicians in San Francisco to increase funding for housing and homelessness services in San Francisco County. And the California Policy Lab is a research sort of think tank that we're working with to understand the intersection between health and criminal justice information. One of the simple things you can do as a physician is to join an organization that's aligned with your interests, even if they're outside of healthcare, and go be on their board of directors and sort of bring the clinical perspective to that. I think it's a really nice opportunity for physicians.
Okay, so I think this is our last one. So we've talked a little bit about this, but how do you become the go-to person, right, if you have your issue that you want to advocate for? And so part of it is just integrating these sorts of skills if you work in an academic setting, integrating them into your job. So you want to publish if you can and speak on your topic of interest. And again, it doesn't have to be a peer-reviewed publication if you're not a researcher. Maybe it can be an opinion piece or a perspective piece, or maybe you give a lecture. Get to know the media relations contact at your institution. So if you have a paper coming out, Hemel and I will, as long as we don't forget to miss the embargo date, and it comes out and we completely miss the opportunity, we will get ahead of our media relations person ahead of the embargo date and say, hey, are you interested in this? Like, what do you think? Should we do a press release? And then, as Hemel mentioned, partner with professional societies and that sort of thing. I was on the California ASAP board of directors, and so that kind of got me in and kind of understanding some of the issues on a state level. say yes to opportunities for leadership. You said you join everything, so that's great. Keep an open mind, be curious, pursue interesting leads. So I really do think it's important to kind of be a person of yes, and if you end up not liking something, you don't have to do it after that, but kind of explore. And then have your elevator pitch down. So the elevator pitch is just kind of like if you were on an elevator ride with someone and they said, "Hey, what are you interested in?" and you didn't realize it's some funder or someone else that's important. What can you say to just grab their attention in like the 30-second elevator ride? So just put a little something together and maybe test it on somebody. Anything else on that, Hemel?
No, that's great. I think we were going to ask you all to commit to something to advance your sort of advocacy efforts in the next 2 weeks. We don't have to do the exercise here, but I do want to encourage you, if that is your goal to affect curricular change at your institution, think about what you can do in the next 2 weeks to push that along, whether it's connecting with the Dean of Student Affairs at your place or whatever it is. I encourage you to think of like a different SMART goal that you could pursue in the next 2 weeks and use this technique of sort of self-accountability and accountability for your partners and stakeholders to move some of your work forward.
Yeah, and maybe talking to your chair or whoever about how can we get all of our providers X waivers and credentialed, that kind of thing.
I think that's what we got.
Okay.
Yeah.
That is it.
Thanks, everyone.
Thank you.
Well, wow. Thank you, everybody. We've had a rock star lineup. Thank you to Liz for putting this all together. Thank you all for staying till the end. I'm hoping everyone got some actionable things to move forward with after today. Thank you to Jahan and Hemel, who are inaugural chairs of the Social Emergency Medicine and Population Health Interest Group at SAEM. The meeting's Friday morning at 8. For all of you that will be around, we'd love to see you there. And hopefully go forth and advocate. I think we pass around a sign-in sheet for emails. We'll probably try to reach out in a couple months to see where everybody is in terms of hopefully finding something useful from this, just as feedback for all of our speakers. And also, I think all the speakers here are some of the leaders in social emergency medicine, and please feel free to reach out. A lot of them have been great mentors to me personally, and I'm sure would be very happy to work with you individually. Thank you again. Hope you guys have a great conference.